Ahmed. I'm a graduate of SMC class 1988, and today I'm going to talk about ventilator management in intensive care unit. Before we talk about ventilator management, I'm going to talk about normal mechanics. Normal inspiration generates negative intrapleural pressure, which creates a pressure gradient between the atmosphere and the alveoli, resulting in air inflow. In mechanical ventilation, the pressure gradient results from increased positive pressure of the air source. Peak airway pressure, it represents the total pressure needed to push a volume of gas into the lung during inspiration, and composed of three things: pressure resulting from inspiratory flow resistance, resistive pressure, the elastic recoil of the lung and chest wall elastic pressure, and the alveolar pressure present at the beginning of breath, that is positive end-expiratory pressure, PEEP. So peak airway pressure is equal to resistive pressure plus PEEP plus elastic pressure. Plateau pressure, also known as alveolar pressure, the plateau pressure is the pressure present in the alveoli at the end of inspiration. It is directly proportional to the volume, so larger the volume, larger the plateau pressure, and inversely proportional to the compliance of the lung. And then you have to add PEEP to it as well. Positive end-expiratory pressure, it is the pressure maintained in the airway at the end of exhalation. It could be intrinsic, that means set by the clinician, or extrinsic, that means developing due to inadequate exhalation time, known as auto-PEEPing. Increasing PEEP maintains further lung inflation, prevent collapse of alveoli, and improve oxygenation. It's useful in diffuse lung diseases such as ARDS and diseases characterized by stiff lungs. The relationship between FiO2 and compliance. So if the compliance is normal, we generally use lower PEEP. So for example, FiO2 of 30%, PEEP of 5, 40%, PEEP of 8, and FiO2 50%, PEEP of 10, and so on. In case of low compliance, we need to have higher PEEP in order to keep alveoli open, and the ratio of FiO2 to PEEP is, if it's FiO2 30%, PEEP of 10, 40%, 12, and 50%, 14, and so on. Compliance and elastance. Compliance is the opposite or inverse of elastance. Elastance is the tendency of a structure to return to its original form after being stretched. A better way to understand compliance is when you have to inflate a balloon. If you can inflate a balloon very easily, that means that balloon has good compliance. But if you have to really push hard to inflate the balloon, that means the compliance is very low. So it is defined as the change in the volume caused by change in the pressure. Normal compliance in non-intubated patient is about 50 to 170 ml. In intubated patients, now compliance is, in case of male, is 50 to 100, female 45 to 100 ml per cmH2O. Mechanical ventilation. Negative pressure mechanical ventilation, which we don't use anymore. Positive pressure mechanical ventilation could be invasive or non-invasive. I'm briefly going to talk about non-invasive positive pressure ventilation. CPAP stands for continuous positive airway pressure. So if you put a patient on a CPAP of 10, that means there will be 10 cm H2O pressure both during inspiration as well as during expiration. It is useful in conditions such as cardiogenic or non-cardiogenic pulmonary edema, pneumonia, sleep apnea, etc. And a BiPAP or bilevel. In this, you set two pressure, inspiratory and expiratory, and the difference between the two has to be 4 or more in order it to act as a BiPAP. And it's useful in condition where patient has difficulty exhalation, as exhalation is a passive process. So in condition, for example, like asthma or COPD exacerbation, these patients have more trouble with exhalation rather than inspiration. So it's useful in those conditions. Contraindication to non-invasive mechanical ventilation could be absolute and relative. Absolutes include upper airway obstruction, trauma to face, head surgery, respiratory arrest, cardiac arrest, inability to protect airway, or high risk of aspiration, such as patients who have repeated vomiting. Relative contraindications include cardiac instability, copious secretion, uncooperative patient. Let's talk about invasive mechanical ventilation. Ventilator parameters that you need to know include mode, tidal volume, inspiratory pressure, respiratory rate, FiO2, PEEP, inspiratory flow rate, inspiratory time, etc. Tidal volume should be calculated according to ideal body weight and not what the person weighs. Sometimes you can be 400 pounds. It's not that your skeleton is large, you have a lot of fat in your body. So for male, it's 50 kilogram plus 2.3 kilogram for each inch above 60 inch. And in case of female, it is 45 kilogram plus 2.3 kilogram for each inch above 60 inch. Modes of mechanical ventilations, these include AC, assist control, IMV, intermittent mandatory ventilation, SIMV, synchronized intermittent mandatory ventilation, PSV, pressure support ventilation, APRV, airway pressure release ventilation, PRVC, pressure regulated volume control, and PAV, proportional assist ventilation. Assist control. It is also known as continuous mandatory ventilation, controlled mechanical ventilation, continuous mechanical ventilation, assist control. In this, all breaths are mandatory and can be volume or pressure targeted. And all breaths can be patient triggered or time triggered. So what does that mean if it's volume targeted? The clinician picks the rate and the tidal volume. Let's see, if you set the rate of 10 and tidal volume of 500, that means patient is guaranteed to have 10 breaths, and each breath will be of 500 tidal volume. If patient breathes over the set rate, let's see patient is breathing at a rate of 15, that means the tidal volume of each of those 5 breaths will also be of 500 tidal volume. So whenever patient tries to breathe, it triggers the vent and the vent delivers the preset tidal volume. In case of pressure targeted, the clinician set the rate and the pressure during inspiration. So let's see, if you set the rate of 10 and pressure of 15, that means 10 breaths are guaranteed. Each breath will be delivered with pressure of 15. And if the patient breathes over the ventilator, let's see he's breathing at a rate of 15, then each of those 5 extra breaths will be delivered with the same pressure of 15. Assist control mode is the most common and easily used. Now, what is the difference between the volume targeted and pressure targeted? Well, in volume targeted, the volume is guaranteed, while in pressure targeted, the pressure is guaranteed. For example, if you pick the pressure 15, that means the pressure can never go more than 15 during inspiration. But your volume is not guaranteed. Your volume of each breath will vary depending upon the airway resistance and the compliance of the lung. This is a schematic presentation of assist control mode. As you can see, the top one is a flow and the bottom is pressure waveform. The first breath is ventilator delivered, and the second breath is triggered by the patient, as you can see from the negative deflection. Synchronized intermittent mandatory ventilation. This mode was initially invented with the intention of weaning, but later on, lots of studies shown that this mode is inferior to spontaneous or pressure support mode as far as weaning is concerned. Now, just like assist control, it could be volume or pressure targeted. Breath occurs at set intervals. For example, if you place the patient at a rate of 12 breaths per minute, that means every 6 seconds there will be a breath. Patient can breathe spontaneously between mandatory breath, and these can be synchronized. So just like assist control, volume targeted, let's see a clinician set the rate of 10 and tidal volume of 500. That means this patient is guaranteed to have 10 breaths, and each breath will be of 500 tidal volume. But let's see the patient is breathing at a rate of 15. So the tidal volume of those 5 extra breaths will be determined by the patient's effort. And if the patient tries to breathe just before the next scheduled breath, then the ventilator may synchronize that breath with the patient effort. And that's why it's called synchronized mode. Again, in this picture, you can see the first breath is ventilator delivered, and the next 2 breaths are spontaneous breath. As you can see, there is negative deflection, and at the bottom of the green graph, the tidal volume of those 2 breaths is small because those are spontaneous breath. IMV, intermittent mandatory ventilation, same, either pressure targeted or volume targeted, just like SIMV. The difference is there will be no synchronization. That means even if the patient tries to breathe just before the next time breath, the ventilator will not synchronize, and the patient's spontaneous breath tidal volume can be added on the next time breath. A spontaneous mode, as the name indicates, spontaneous means the patient should be awake, alert, and there is no breath is mandatory. All breath are generated by the patient. So in spontaneous breathing mode, the patient breathes on his own. So respiratory rate is determined by the patient. The volume of each breath is determined by the patient. The ventilator just delivers the humidified air and the oxygen to patient. In case of CPAP mode, if the patient is at a CPAP of 10, then there will be pressure of 10 cm H2O during inspiration and expiration. Again, rate is determined by the patient, tidal volume is determined by the patient. In case of BiPAP, the pressure during inspiration and expiration will be different, whatever you fixed. Pressure support ventilation, PSV, same thing. All breaths are generated by the patient. None of it's mandatory. What the ventilator does, it support the inspiration, whatever pressure support you have set, generally 5 to 20 cm H2O. So the volume of each breath is variable, and it depends on the level of the pressure support, duration of the respiratory effort, and lung mechanics. It's a very comfortable mode for alert patient because they can breathe at a rate whatever they want, and tidal volume whatever patient wants, and it's most common mode of weaning. As you can see in this one, pressure waveform, there is negative deflection before each breath, indicating all these breaths are generated by the patient. Bi-vent, bi-level, or APRV, airway pressure release ventilation. It is a rescue mode for patients with refractory hypoxemia as a result of severe ARDS. It is a timed cycle alternate between 2 levels of positive pressure with the main time spent on the higher level, more than 90% of the time, in brief expiratory release to facilitate ventilation. It should be avoided in the patient who have increased secretions and bronchospasm, as it will create auto-peeping because there is very little time for exhalation. Can it be used in paralyzed patients because it's sort of a spontaneous mode and a sense that patient breathe spontaneously on both pressures, higher as well as lower pressure. So the parameter that you have to pick includes high pressure, which is known as P high, and ideally it should be less than 30. Low pressure, P low, should be 0. And the high, T high, that means the time for the higher pressure, usually 4 to 6 seconds, and it is the main driver of release frequency. T low means the time for the low pressure. Initially, it should be 0.5 seconds. So initial settings of APRV. How to choose high pressure? Well, if you're transitioning from volume cycle ventilation, then set the P high equal to plateau pressure. If you are transitioning the patient from pressure cycle ventilation, then set your P high equal to peak pressure. P low should be 0, and the time for the high pressure should be set about anywhere 4 to 5 seconds, and the time for the low pressure, 0.5 seconds. Start with high FiO2 and then titrate it down as long as saturation stays more than 94% on the monitor. Now, if you want to decrease the PCO2 in this mode, you have to decrease the time for higher pressure or increase the higher pressure. If you want to increase oxygenation, then you increase the time for higher pressure or increase the higher pressure. But try to keep the mean airway pressure same. For example, if you decrease higher pressure from 24 to 22, then increase your time for higher pressure by 0.5 seconds. As you can see in this diagram, the time for higher pressure is long, while the time for the lower pressure is very small. And the patient can breathe spontaneously on both pressures. Pressure control ventilation. In this, inspiratory pressure is set by a clinician, rate is set by a clinician, duration of inspiration is set by adjusting the inspiratory time or inspiratory-expiratory ratio. Tidal volume varies depending upon lungs or chest wall compliance as well as airway resistance. It's uncomfortable mode and requires sedation. The difference between this mode and the assist control pressure targeted mode is this. In assist control pressure targeted is whenever patient try to breathe, ventilator will deliver the next breath with the set pressure. But in this, the spontaneous breaths are not supported. Now, pressure regulated volume control ventilation, PRVC. It is the to-go mode in intensive care, most of the intensive care unit here in America, and is known by different names. In case of Siemens 300 Macuate Servo and Vices Avia ventilator brand, it is known as PRVC, while in Drager brand, we call it AutoFlow. In Hamilton Galileo, adaptive pressure ventilation, and in case of CPC Venturi, variable pressure control. Pressure regulated volume control. In this, the clinician set the minimum respiratory rate, pick the tidal volume, and also will set upper pressure limit. So what it does, the ventilator in this senses the exhale tidal volume. Let's see if you want to have tidal volume of 500, and the first breath was 400 tidal volume. So the ventilator senses how much exhaled air came, and then accordingly increases the pressure for the next breath in order to keep tidal volume of 500. So here is the kind of good graphic presentations. So tidal volume is measured. So ventilator compare the exhaled tidal volume. If it is more than what you wanted, then the inspiratory pressure for the next breath will go down. And if the exhaled tidal volume was less than what you wanted, then the inspiratory pressure for the next breath will go up to keep that tidal volume. And if it's the same, for example, you wanted to have 500 tidal volume and the exhaled air was 500, then ventilator will not change pressure for the next breath. What are the advantages of this PRVC mode? A decelerating inspiratory flow pattern, pressure automatically get adjusted for changes in the compliance and resistance within a set range. Volume is guaranteed, so it limits the volume trauma and also prevents hyperventilation. Pressure control inverse ratio ventilation. Normally, exhalation is 2 to 3 times of inhalation. So expiratory time is 2 to 3 times of inspiratory time. So in this pressure control ventilation, we set the inspiratory time more than the expiratory time. So we inverse that ratio to create auto PEEPing, to keep alveoli open. So it is very uncomfortable for the patient. In order to use this mode, patient has to be heavily sedated and paralyzed. It is generally used as a rescue mode for very stiff lungs, where you can't ventilate the patient with assist control, volume targeted, or pressure targeted. Now, ventilator focused rescue therapies in refractory hypoxemia. These includes lung protective ventilation with high level of PEEP, as was used in ARDSNET trial, pressure control ventilation, pressure control inverse ratio ventilation, which we don't use too much. The mostly we use is APRV, airway pressure release ventilation, as I described above, and lung recruitment maneuvers. ARDSNET recommendations for mechanical ventilation. These include assist control mode. Start with tidal volume of 8 ml per kg of ideal body weight, then reduce by 1 ml per kg of ideal body weight to 6 ml in order to keep your plateau pressure less than 30. And if the plateau pressure remains more than 30 with tidal volume of 6 ml per kg of body weight, then further reduce it to 4 ml per kg of body weight. Keep saturation 88 to 90% and pH of more than 7.29. The ratio of FiO2 and PEEP used in ARDSNET trial is given here, which was published in New England Journal of Medicine on May 4, 2000. So for FiO2 of 30%, PEEP of 5, 40% 5, 50% 8 to 10, 60% 10, and so on. Lungs recruitment maneuvers. Recruitment maneuvers aim to improve oxygenation by increasing transpulmonary pressure to open atelectatic alveoli. And these are done by two ways. Sustained high pressure inflation using pressure of 30 to 40 cm H2O for 30 to 40 seconds, and a stepwise increase in PEEP from 25 to 35 to 45 for 1 to 2 minutes of feed. Studies have shown that sustained high pressure inflation is much better than incremental methods and reduces mortality. However, both carries the risk of barotrauma and transiently drop the blood pressure. Non-ventilatory strategies to improve oxygenation in case of severe hypoxemic respiratory failure, such as ARDS. These include neuromuscular blockade, inhaled vasoactive agents such as nitric oxide and prostacyclins, and prone positioning. If nothing works, then ECMO. Inhaled nitric oxide causes selective vasodilatation of pulmonary blood vessels in ventilated lungs that may lead to improved ventilation perfusion matching, better oxygenation, and lower pulmonary artery pressure. Use of neuromuscular blocking agent in refractory hypoxemia in ARDS improve oxygenation by improving chest wall compliance, decreasing oxygen consumption, and eliminating patient ventilator asynchrony. Prone positioning. Potential physiologic benefit for prone positioning include more homogeneous pleural pressure, dorsal lung is better perfused and aerated, thereby decreasing intrapulmonary shunting, improving VQ matching, improved lung recruitment, less ventilator-induced lung injury, decreased release of pro-inflammatory cytokines. In order to have beneficial effect of prone positioning, it needs to be done at least for 12 to 16 hours a day. Monitoring of patients on mechanical ventilation. One thing is for sure in my experience, as soon as you intubate these patients, they tend to drop their blood pressure. And the reason for that is medication that you use to intubate the patient for induction and for sedation, they drop the blood pressure. Second, you are converting from negative pressure ventilation to positive pressure ventilation, and that will decrease the venous return. And also, you're intubating this patient because they were in respiratory distress, and their sympathetic stimulation was sympathetic stimulation was high, and that while keeping the blood pressure falsely within the normal range, but once you intubate, they tend to drop blood pressure. So it's a good idea to give patient 500 normal saline bolus just before intubating if there is no contraindication. So once the patient is intubated, the role of ABG and chest X-ray, you need to have initial ABG to see your vent setting if you want to make any change, and a chest X-ray to confirm your chest tube your ET tube placement. After this, do you need to do chest X-ray every day? Personally, I do not, especially for pneumonia or for ARDS. But if the patient has fluid overload, I might do it more frequently to see my response to diuresis. ABG doesn't need to be done every day unless there is acid-base abnormality. Otherwise, you can follow oxygenation by monitoring saturation on the monitor. You need to monitor airway pressure, volume, flow on a daily basis. If there is increased peak airway pressure, then you need to know if the plateau pressure is also increased. So if the difference of the peak airway pressure and plateau pressure is more than 5, that means the problem is with increased airway resistance. And that can result from bronchospasm, mucus plugging in the ET tube, or patient may be biting on the ET tube, narrowing of airway circuit. If there is increase in peak airway pressure as well as plateau pressure and the difference is less than 5, that means there's a problem with the lung compliance or chest wall compliance. That means you're dealing with conditions such as pulmonary edema, ARDS, pneumonia, pneumothorax, or auto-PEEPing. Patient ventilator asynchrony, it could be triggering of a breath asynchrony, inspiratory flow asynchrony, cycling asynchrony. Ineffective triggering means the patient trying to breathe, but the ventilator in assist control mode will not deliver the breath. Occurs when the patient does not create sufficient pressure change in the airway or flow to initiate the positive pressure breath. Or maybe you have respiratory therapist has set the sensitivity too high. So most common cause is auto-PEEPing, other causes weak inspiratory muscles, partially blocked endotracheal tube, or high trigger sensitivity. As you can see in this diagram, the arrow, the patient's trying to breathe, but the ventilator is not delivering the breath. Double triggering occurs when the ventilator inspiratory time is shorter than the patient inspiratory time. In order to fix this, either you have to increase the ventilator inspiratory time or increase the tidal volume or use more sedation or switch it to variable flow setting. Again, at the arrow, you can see there are two breaths right on the top of each other that is double triggering. Auto triggering occurs when the ventilator is triggered without patient initiating a breath. Typically occurs because of circuit leaks, fluid in the circuit. If the patient has a chest tube, then the chest tube leak or vibration from the ventilator tubing. In this diagram, you can see there is fast ventilator rate, and in the bottom, there is no negative deflection. That means patient is not doing this thing. Now, sedation in ICU. All these patients who are on the ventilator need sedation. The most commonly used drugs include benzodiazepine, propofol, Precedex, remifentanil, Fentanyl, and morphine. The benzodiazepines we don't use too much and mostly use propofol and Precedex. Benzodiazepine tend to cause more delirium, increase ventilator day and ICU stay, while the propofol and Precedex are short-acting, easily titratable, and cause less delirium. Remifentanil used as a sedative and mostly in a surgical intensive care unit. A busy slide, but has lots of information. It has name of the medication on the left-hand side, mechanism of actions, typical adult dose, pharmacokinetics, and adverse effects. Assessment and monitoring of sedation. All these patients should be mildly sedated. Only in few cases you need deep sedation, such as patient with increased intracranial pressure, status epilepticus, severe ARDS with high FiO2 and PEEP, or patients who are on neuromuscular blockade agents. So scale, there are two most commonly used scales to monitor sedation. One of them is Richmond Sedation Agitation Scale, Ross scale, and Ricker Sedation Agitation Scale. Ross scale, the number varies from -5 to +4. More minus means deeper sedation, more plus means more agitation. So you want to keep your Ross score -0 to -1 to -2. Sedation vacation. All these patients, other than few that I mentioned, where you need deep sedation, the sedation should be interrupted every day and let the patient be awake. For assessment, the consistent message from all sedation interruption trials is that minimizing sedation among patients in the intensive care unit provide clinical benefit, especially when coupled with a spontaneous breathing trial. Benefits includes overall less use of sedation, fewer mechanical ventilator days, and fewer ICU days. I just want to mention ventilator bundle, what it is. The ventilator bundles include all these things. You have to elevate the head end of the bed to 45 degrees to prevent aspiration, daily sedation vacation, and assessment of readiness to extubate, daily oral chlorhexidine rinses, proton pump inhibitor or H2 receptor antagonist for GI prophylaxis, and for DVT prophylaxis, either sub-Q heparin or Lovenox or compression devices. Now, weaning from ventilator. The weaning from ventilator is basically a common sense. First of all, the problem for which the patient was intubated has resolved or significantly improved. Second is off of sedation. Is patient fully awake, alert, follows commands, making eye contact? Is cough strength is great and there is not much secretions? And on a spontaneous breathing trial, their shallow respiratory index, that means the respiratory rate divided by the total volume in liter, is less than 125. Lower it is, more patient seems to be ready to be weaned off from the vent. Patient should be hemodynamically stable. That means the patient should not be on high dose of pressors to maintain their blood pressure. You don't want to extubate those patients because they can crash anytime. And your FiO2 should be less than 50 with PEEP less than 8. And patient should be able to tolerate spontaneous breathing trial for 1 to 2 hours, depending upon for how many days they were on the ventilator. And during a spontaneous breathing trial, there is no increase in blood pressure, no increase in heart rate. Before extubation, you want to make sure there is no upper airway swelling, and you have to do what we call cough leak test. For that, you need to put patient back on volume control mode, suction their upper airway, and then deflate cough and see if the exhale total volume goes down by at least 15% or more. That means the air that is being pushed, 15% or more, is being exhaled around the endotracheal tube. And that means there's no swelling in the upper airway and you can take the tube out safely. Complication of mechanical ventilations: pulmonary barotrauma, pneumothorax, pneumomediastinum, pneumopericardium, dynamic hyperinflation, and auto-peeping. Mostly is a problem when, in case of assist control, if the patient breathes faster than doesn't have time to exhale the airs. And with each successive breath, there is more and more air in the alveoli, and it causes lung distension, which decrease your venous return, that leads to decreased cardiac output, that leads to decreased blood pressure and tachycardia. Other includes ventilator-associated pneumonia, trauma or dysfunction of vocal cords, and late complications such as stenosis of trachea and tracheomalacia. Now, surviving sepsis campaign guidelines on the management of critically ill adults with COVID-19. These recommendations are from Society of Critical Care. Just to summarize them here is to maintain the saturation in these patients 96 or above. And if patient require more oxygen that cannot be given by the nasal cannula, then you should use high flow nasal cannula, but try to avoid BiPAP because it will generate aerosolized. And also try to prevent bronchodilator given by nebulizer treatment. If these patients need bronchodilator, give them by MDI. If they get intubated, you should have low threshold to intubate these patients once they go on high flow nasal cannula. And if they get intubated, then use low volume lung protective ventilation, 4 to 8 ml per kg of ideal body weight. Keep their plateau pressure less than 30 and use higher PEEPs. In case of moderate to severe ARDS, put them in a prone positioning 12 to 16 hours. And in severe ARDS and hypoxemia, despite optimizing ventilation and other rescue strategies, give them a trial of inhaled vasodilator as a rescue therapy. But if no rapid improvement in oxygenation is observed, then treatment should be tapered off. In mechanically ventilated adults and refractory hypoxemia, despite optimizing the ventilation and use of rescue therapies and proning, then consider using ECMO. And I've given the link for Society of Critical Care Guidelines. Thank you very much. For any feedback or question, please send me an email, waseem.waseem077@gmail.com. Thank you and have a good day.